So how is everybody tonight? Everybody hanging in after the first exam? I think all in all, first exam went really well. I apologize. My voice is a little crackly, sexy, raspy, because it's not an illness. What it is rheumatoid arthritis can affect all joints. There's a joint in your voice box and it's attacked it. So I've got this raspy voice. So I'm going to try to speak as best I can for you. I apologize that I've got this raspiness going on, but I don't feel bad. It's just this drives me crazy. Do you believe it's week 5 already? We're almost halfway through. Now, week 7 is your next exam, and I will be sending out your exam 2 PowerPoint study guide by the end of the week. I am almost done with it, so you'll have it earlier. And we will be arranging what reviews are for next week. So it goes pretty quickly. This week, we're covering chapters 40 and 42, respiratory and cardiac. And I really think they're the most difficult of all the chapters. Respiratory and cardiac are rough, but if you think about it, heart goes with lungs and lungs goes with the heart. So it all makes sense to put them together. Remember, you have a discussion question and you do have a quiz due by Sunday. So make sure you do get that done. The dean has asked me if you would to make sure, if you can, to do the evaluation, course evaluation midterm, if you'd get that done, to let her know how things are going, how you're feeling about what's going on. So anybody, any questions? Anybody who wants to meet me for a one-to-one to review your exam, I don't care if you got a 96 and wanted to know those 2 questions you got wrong, or if you got something lower. You know, if you just want to know what concepts you missed, I will definitely tell you what they were so that we can make it better for HESI and for your NCLEX. Just let me know. Send a message, please. So let's go on with our PowerPoint. Let's start there. So respiratory, cardiac, chapters 40, 42. I hope that you've done at least the interactive PowerPoint, because there's a lot of stuff here. There's a lot of concepts that are very difficult to understand. I'm going to try to make it easy for you. So respiratory infections could be in the upper oropharyngeal airway, or it could be down lower, which are more like your pneumonias. Most upper respiratory in children are viruses. Yeah, you can have some bacterial infections, but it's mostly your viruses that you will see. So you take your kid to the doctor and he's going to tell you, well, you have upper respiratory infection. And he's going to say Tylenol, Motrin, and fluids. So most of all, that's what it is. And then after 3 days, if you don't get better, then he'll put you on antibiotics. But initially, it'll be just putting them Tylenol, Motrin, because it is a virus most of the time. Now, when we talk about infections, we talk about a child's ability to fight them. So for the first 3 months, you have mom's antibodies. They're in your body. They work. And it really protects that infant. And you know that we give immunizations at 2, 4, 6 months. And we load up a lot of these immunizations to be 4 or 5 every visit. But we're trying to make that child not get sick from these really horrible diseases and give them some protection. After they get older, the infection rate, yeah, it's going to get more because mom stuff goes away and you're going to get these viral infections and strep throats and ear infections. And, you know, your body starts building up that immune system. By the time you get to be toddler preschool, remember everything in the mouth. They like to swap spit, toys, everything. They explore the world through their mouth. So they're going to be getting all these infections, but it's okay because getting these infections, what's happening? that body is now building up an immune system to be able to fight it in the future. Yes, as you get older, it's going to be more of the bacterial infections, but the end result is as we get older and get these infections, your body builds up that immunity. So your ears, we've got these little short little airways that are wide open, and we get infections right away in our ears. We got these big tonsils, big adenoids. The mucus sits there and goes up into the ears. And probably one of the most common infections in children is, ear infections. Now, what is a kid going to look like? Well, they're all different. Every child's going to act differently. You have one child who may just go in the corner and not want to play. You might have one child who just doesn't want to eat. And when you see a child not eating their favorite food or drinking their favorite drink, check their head. Probably they're with a fever, or if they don't want to play like they normally do. Fevers usually puts these kids be able to sit in the corner and really feel miserable. So that's why we medicate these children, because fevers make a kid feel bad. Once they have the fever down, they're going to eat, they're going to drink, they're going to play, and it's like they never had an infection. But, treating the fever is important. I mean, some of the signs you might see is kid stops eating. They might vomit, have some diarrhea, tummy might hurt. They might have that sore throat or cough. And you might hear some, upper respiratory mucus and, mucus coming out of their nose, this big green boogers hanging out. It's just part of what you might see. But the important thing is to manage that fever, and that promotes them to drink and to eat, which is part of getting better. So if they're having problems with respiratory, we want them to blow their nose, get rid of those secretions. We want them to rest. And then, of course, we want them to use tissues, cover their mouths, etc., so we don't spread this around to everybody. So these ear infections, how do we treat them? So these are inner ears get full of mucus. Now, our oropharyngeal airway has staph normally in it. And we have those big tonsils and adenoids, which pushes that mucus to go up into those, eustachian tubes, which goes into those middle ears, and it gets swollen. And otitis media hurts. And one of the major things, priority care on these children, is to give them something for pain. Number one, because the pain stops them from eating and drinking because it hurts. You tell a little kid, which ear hurts? They'll take the right hand and put it this way, or the left hand and go that way. And it could be a 2-year-old, and they'll do that. They know it hurts. So how do we treat otitis media? Well, it is an infection. It is staph, like your oropharyngeal airway has all the time. So we treat it. Amoxicillin, Augmentin. We don't have to go with crazy antibiotics, and that usually will cure it. Now, if a kid is with chronic ear infections, 3, 4, 5 a year, then this is when they decide to put the tubes in. And those tubes just help the middle ear drain and keep the infection and the buildup away. And, that's what they do for it. And again, remember, it's the nursing care is to help the child with pain. The prevention of reoccurrence, keeping that nose blown and mucus away from it. But if you have children at home and they have an ear infection, I'm going to tell you, it's just a little nursing tip that I teach my parents. Have them sleep on 2 pillows at night, because when they lay down, their eustachian tubes pull back and it hurts more. So if you want to get some sleep, medicate them with some ibuprofen and then have them sitting up better. And they're not going to have as much pain at night, because that's when they hurt. Now, infectious mononucleosis, it's a kissing disease. It's not a big deal, right? Well, infectious mononucleosis is due to a virus, like a herpes, like Epstein-Barr. And Epstein-Barr is that virus that makes you feel weak and tired, and you can't move, you have a fever. But along with that is that sore throat, swollen lymph nodes, armpits. You might even feel the liver and the spleen below the rib cage. it's all swollen. So the usual treatment for infectious mononucleosis is you go to the doctor complaining of fatigue, fever, sore throat, body pains. Yeah, you got some swollen glands. So they do a strep test, maybe a flu test, and they're negative. He said, you got a virus, Tylenol, Motrin. Well, a week later, you're still bad. You might go back to the doctor, might go back to urgent care or ER. And we're seeing it's lasted for a week now. We might put you on antibiotics and send you home. Or if they come back a third time, we're definitely going to draw some labs. We'll do a CBC. We're looking for the white count. In a virus, the white count is normal. With a bacterial infection, white count's going to be elevated, right? So we do also with a CBC a monospot test. Now, monospot test now comes back positive. What does that mean? And what do you need to teach those parents? Well, you've seen the swollen liver, the swollen spleen. Your abdomen is big and swollen, and we need to protect the spleen and the liver from any sort of anybody hurting, pushing, hitting, because the spleen is fragile and it will burst. So we tell the parents and the child, no PE in school. If you have brothers and sisters, no roughhousing at home. All you need to do is rest, Tylenol and Motrin, because it is a virus, like I said, plenty of liquids. And they can't go back to play PE until they get cleared by their normal pediatrician. Now, let me explain what can happen if the parents don't listen carefully. Now, I had a little boy, 9 years old, that all that stuff had happened. I did the monospot test, CBC. CBC was fine. Monospot test positive. Him and his dad had come into the ER one Saturday morning. So we told him, protect that belly, no PE, no sports, that they had to be calm for a minimum of 3 weeks. Well, 1 week later, I am the primary trauma nurse on, which means any trauma came in, I'm in charge. Well, we get a call. We get rescue coming in. 9-year-old boy fell off a trike in the Everglades, fell on his belly. When he got to me, he was already dead. His spleen had ruptured. Parents didn't listen to what we said. Why was he on a trike when we told him, protect the belly, no PE, no sports? And I'll never, ever forget it. I'll never forget the kid. I'll never forget that father, because the physician told him and I re-emphasized it, and it happened. So if anything you take from this lesson, anybody with mononucleosis, make sure they protect their belly. And if you go to pediatrics, make sure you teach them that. A respiratory condition also that can happen is called croup. And it is a very loud barking cough that is you'll know it's croup when you hear it. Croup is a viral infection. We treat it with just steroids because it'll decrease the inflammation in the oropharyngeal airway. Now, it can go further and get worse, and it could go to epiglottitis. Now, what is an epiglottis? Well, what is the epiglottis? It's that leaf-like structure that covers the trachea when you swallow, so you don't aspirate food. Well, this swells up over the trachea, and you can't breathe. Okay, think about something over your trachea. Air can't go in. So you're in severe inspiratory stridor. You can't get air in. You can blow it out because you can sort of puff off that leaf-like structure, but getting it in, you can't. So what will the child look like? Well, they'll have pain, their throat will hurt, but they'll be drooling. They can't even swallow. And they'll be bent over trying to put their head and neck in a position where they can get a little bit of air through their epiglottis. Maybe there's a little space left over. So when that child comes in, what is our priorities? Well, of course, it's airway, but we need to make sure there's an intubation tray or a tracheostomy tray right there at bedside, because we know we can't go so long without breathing, right? Where is it? There we are. So When we treat epiglottitis, what do? Well, number one, never ever look inside the mouth because you don't want to increase the swelling in there. Okay. You can see it, you know what's happening, you'll see all the signs and symptoms of it. And we're going to be giving steroids and racemic epi-aerosols, which goes directly to it, that will help try to decrease that swelling. Nothing by mouth because they can't even swallow their own saliva, right? Okay, and then laryngotracheal bronchitis is a type of croup. It's just that barking viral thing, again, treated with steroids. So what do you see? Well, they've usually probably have already had a cough and a cold, and then you see it. But when you start seeing a little bit of inspiratory stridor, and you hear that barking, and of course you'll see retractions, you know that that is that croup. We see this a lot in the nighttime. They come in, and many times the change of temperature between the house and outside and coming into the hospital, that temperature change helps ease up that cough. And they'll say, oh, he's been coughing like crazy. It's been really like a seal out there. And we're like, oh, okay. So we knew what was going on. And these children, again, how do we treat them? We give them one injection of Decadron, or we give them a bunch of oral steroids, and that will help decrease that swelling in there. If we do not treat the swelling in the airway, it's going to lead to epiglottitis or respiratory failure because you're not going to be able to breathe. So as I said, maintain that airway. Nothing by mouth on these severe cases. I mean, regular croups are walking around fine because they're not to the point yet. They will get some missed oxygen. So there'll be a mask that's connected to a bottle which has water in it, and it gets a little bit of mist, and that's comforting for the throat. Again, we'll give that racemic epi and the aerosols and the steroid to decrease that swelling. RSV, bronchiolitis, same name. Bronchiolitis is RSV. RSV is bronchiolitis, respiratory syncytial virus. This is a common cold for you or me, but for an infant, it's extra secretions and a low-grade fever, which makes them miserable. You know, as an infant, the early ages, 1 to 6 months about there, it's hard enough to suck, swallow, and breathe. Then you put a little fever in there, they don't feel good, and put all this mucus in their upper airway. They can't breathe, so they can't eat. So it needs to be treated. Now, what if this kid was a congenital heart defect? What if they had cystic fibrosis that was diagnosed at birth? What if there are severe, premature with, lung issues? And then you give them RSV, that's a very dangerous situation. So what do? Well, there's an immunization monthly from the fall to early spring. So it's around fall, early spring. They give every month one injection for it, and it prevents RSV on these children. And we do give it to the children, because it is a lot for these kids to keep up with. And if you're already compromised with some sort of autoimmune or cardiac problem, respiratory problem, it could really cause them a lot of issues. Now, pneumonia is another one of the things kids can get. My career, what I have seen is children come in, cough, maybe they vomited mucus, fever of 101 to 102, and they bring them in because they're not eating and vomiting usually in the little fever. So I listen to their chest and I go, oops, I don't hear that left lower well. I bet you it's a left lower lobe pneumonia. And this picture is a left lower lobe pneumonia. You see all that white consolidation is on that left side. Yep, and it is treated with antibiotics. It is a consolidation of a lot of different, mucus in there. Now, Pneumonias can be caused by bacteria, viruses, but you will always see, usually if you have pneumonia, we're going to be treating them. For the mycoplasma, we're going to give them two different types of antibiotic for positive germs and negative germs. And then the pneumococcal, we now have a vaccine for it because it really is a difficult pneumonia to cure. And we don't want our children to get it. Pertussis, we give it a vaccination, right? For that immunization is given right after birth at 2 months because it's such a severe respiratory illness that we don't want them to get it. And pertussis is extremely contagious. Now, I saw some cases, there was like 5 different cases, around this area back a couple of years ago. And we were alerted about it because it's extremely contagious. So, I mean, I make sure I wear a mask when I know a child's not immunized. I've never gotten sick from a kid in 10 years working in a pediatric ER because I always washed my hands, I wore my mask. And I've told you I'm immunosuppressed. I have rheumatoid arthritis, so I got to be really careful because I'm on those drugs that make me extremely immunosuppressed. So I wore them a lot. Now, pertussis is airborne. It's in the air. It's all out of coughing that goes on with it. Most of these children, because they need a long-term treatment, are admitted to the hospital. Now, rooms in the hospital, the air circulates all over the hospital within it. The children that are with pertussis get a room we call the laminar airflow room, and the air flows out of the hospital. It doesn't come back in. It's recirculated out. It's special because we don't want to just take all of these germs and pump it in the hospital, right? So we know there's vaccines. We know it's highly contagious. We know it can be prevented, but there are parents who decide that they don't want their children immunized, whether it's religious or whether it's personal beliefs. And, that's their right to do what they want. I immunize for everything, but whatever you do, you do. Foreign body aspiration. Well, we know kids explore the world in their mouth, right? Everything goes in their mouth. The one thing I saw more than once, 3, 5, maybe 10 times in these 10 years that I worked in the ER was quarters, not pennies or dimes, quarters they swallow. And you can see this picture. This is a picture I had of one of my kids right there. And it sits and it can't go down and they can't get it out. And it hurts, it's uncomfortable. And they're drooling because they can't swallow because it's stuck in the way. So how do we take care of this? Well, these kids, I thought when I first saw it, the children would go up to the OR, have a bronchoscopy. They'd go down with clips and pull it out. Well, that would be an overnight stay and sedation and anesthesia, right? No, what they do is the surgeon comes, puts the child on their lap, takes a Foley catheter with a balloon on the end, puts the catheter down the throat below the quarter, blows the balloon up, and leans them over and pulls it out. And what I do to stop their fear is I said, when he pulls that out, the quarter's coming, and if I get it first, it's mine. So the kid, instead of being scared, jumps to the floor and tries to grab his quarter. So is that distraction to the max or what? That's how you treat children. I've never had a kid afraid, as I treated them that way. So think of these crazy little things if you ever want to work in pediatrics, because it really works. So I said I went to work to play for my 20 some odd years in pediatrics. I loved it. I could play. I have seen a French fry be aspirated, and the outcome wasn't good. The kid ended up going on ECMO, which is like a heart-lung machine that just oxygenates, and the kid after 3 days died from a French fry. So, I mean, the bottom line is you have to be really careful with children eating things and paying attention, et cetera, because they can aspirate so easily. Again, it's always with these children monitoring airway. Now, the other aspiration, pneumonia, could be due to good old baby powder. I mean, years ago when my kids were little, they didn't know about this stuff. I love Johnson & Johnson baby powder, and I used to put them all over. It smells so good, right? Well, that talcum in the air goes in their lungs and it could damage their lungs. So who knew I was killing my kids' lungs back then? But then we figured it out, because that's what medicine does. They figure it out after a while. Another thing is, have you ever gone into your bathroom, cleaned the tub with bleach and a chemical, and you smell that stuff and it hurts your lungs? You got to be careful with kids with that. Even strong perfumes can hurt children's lungs. So just be aware of those things. Another thing that can cause aspiration pneumonia is just feeding a child. That's why burp a child well. Make sure that they're burped well when they're done. Don't overfeed them, and sit them up when they're done for a while afterwards. Don't put them directly down on their backs to go to bed, because you will have aspiration. Sitting them up can help prevent that. Now, another lung issue called the worst of the worst, acute respiratory distress syndrome. This is whether it's an injury to the chest, whether it's overwhelming sepsis. Teenagers, drug overdoses can cause this. And of course, I live in South Florida. What's all over the place? Swimming pools and lakes and ponds and oceans. There's just all this water down here. And many drownings have I seen that do occur. Now, when the lung gets damaged, it's such a difficult thing to try to treat them. Many times they end up on this ECMO. And if you look at all of this blood stuff is coming out of this baby's neck, going to the machine, it just takes the blood, puts oxygen in it, and puts it back in the child. It doesn't support the heart, it just supports the lungs. In fact, I ended up certified to do ECMO on children, because I just wanted to know what it was all about, because I'm one of these people who wants to know everything about everything. You know, I have this issue with trying to understand. So we would run it. Now, what it does, the lungs can rest because it doesn't need to do anything, right? And then we could be giving aerosols and treating those lungs and letting it heal. And eventually, slowly, we give the work back to the baby or the child to be able to work. I mean, you can do ECMO on a child to an adult, doesn't matter, depending on the situation. Still, respiratory distress syndrome is a very difficult thing to come back from, and many children still die. Asthma. You have asthma, your child has asthma, somebody you know has asthma, there's a word you know about. And basically it's a hyper-responsiveness of the bronchus, the bronchioles. They get swollen and you get air in, and then you have this prolonged expiratory phase trying to get the air out of you. I mean, if you ever listen to lungs of a severe asthmatic, my husband ended up in the ICU for 12 days. With status asthmaticus, as I called it. And all I could hear was on expiration, a little, and that's all I could hear. No air was moving at all. It was so swollen in there. So asthma is probably due to some allergen they got in them. And it creates this bronchospasm, that the hyper-responsiveness bronchospasm. So we need to prevent future ones, right? That's our goal in asthma, to prevent it and keep children as normal as they can, keep them in activities that they love. So we test their lungs. How are they working? Are they, good tidal volumes, etc.? Testing them for allergies, huge. It could be the cat, could be the dog, could be the grass outside. And if you could prevent a future asthma attack, let me tell you, if you've ever seen what I saw with my husband, I never want to see him like that again. He could not breathe at all. And it was the fear, like he was drowning, because he couldn't breathe, couldn't get air in. And it's not cool. So we do everything to prevent that now. And since then, thank God, no other issues at all. So pulmonary function, skin testings. And if you look down here, these are little spacers. You take that little meter dose inhaler, put it on the end of it, squirt it, 1 puff, 2 puffs, whatever the doctor orders. And that little spacer holds the medicine, and that mask around the mouth holds it. So the child breathes in and out. I don't care if they're crying. In fact, it's better. They breathe deeper and they get the medicine into their lungs, and it can help an asthma attack. So if you have a child comes into the ER or the doctor's office, he's been using this thing for 3 days, it's getting worse and still wheezing, ask them how they were giving it. Did they use a spacer or not? Because a 4-year-old to squirt it and inhale, I'm sorry, not many 4-year-olds can do that. So that little spacer helps. There's many adults who can't do it, squirt it and inhale. So they use a spacer. It's from babies to adults, they use these things. So treatment, how are we going to long-term treat these children? Well, we need to have, of course, the rescue, but it's only when you can't breathe good is a rescue. That's not like a daily dose thing. It's as needed, PRN. We will be giving these things in children. It's a preventative medicine called Pulmicort. In adults, you might see things like Symbicort, Advair, Brio. It's only morning and night. Has a little bit of steroids in it, and it prevents those lungs from getting tickled with these allergens. So that's preventative. The other thing we give them is a pill at night called a Singulair. It's Claritin for the lungs, basically. It's very similar, but it's specific for the lungs. So we give those also. And then in attacks, this chromalin sodium is called Atrovent, and we give that in acute episodes to try to keep them calm and cool. We give them albuterol too. So we mix them together actually, and it works well. Now let's go into the hearts. Now hearts, what do we look like? Well, cardiac, you think of adults, you always think of congestive heart failure and myocardial infarctions. Well, children are not like that. Yeah, they go to congestive failure. We're going to go into that. But we're talking mostly about these congenital heart defects babies are born with. Sometimes we know they are, and sometimes we do not know that they're going to be a congenital heart defect. And they're at birth where they're born with it. Now, there is times like that viral infection could affect the heart, cause severe cardiomyopathy, like a big floppy heart that doesn't beat right. So that runs into issues. It could be autoimmune. Think about lupus. Doesn't lupus attack the heart? So that could be the acquired type. And of course, the environment and then any familiar history can cause it. Now let's take the heart. This is pictures in your book. It's a great picture. Think about the heart as a garden hose because blood flows around the heart right? So you need to know how a drop of blood goes through the heart and the names of the structures. Right atrium, tricuspid valve, left or right ventricle, pulmonary valve, pulmonary artery, pulmonary vein, left atrium, mitral valve, left ventricle, aorta, and to the body. You need to know that. So if we have that red side with those 3 things that go up, subclavian arteries that go off the aortic arch, let's say right after the aortic arch, it's very narrowed or kinked. So blood can't, a little bit gets down there, but not much. Where's that blood gonna go? It's gonna go back into the left ventricle, right? It's gonna go back to where it came from, left ventricle. It's going to go up through the valve into the left atrium. It's going to go back into the lungs and fill up with fluids. We know that's going to happen because it's got to go somewhere. Kink of a garden hose, right? What are you going to see as a nurse? What do you expect? Well, I diagnosed one of these in my very early pediatric career, and I was so excited. What I saw was no pulses or extremely minimal pulses in the lower extremity. That kink didn't allow a lot of blood to go down there, right? So when I felt those little nothings in the feet, what did I do next to make my diagnosis? I did a 4 extremity blood pressure, which means I tested both legs and both arms. What did I see? Well, hardly any blood is going down there to the feet, right? There's no pulses or very minimal. Low blood pressures down below. because that blood was going back. Yeah, some went up into the head. Some older children feel headaches or get nosebleeds by the amount of blood that's coming, because sometimes it's not diagnosed immediately. As an infant, you'll see it go back into the left ventricle and stretch it. Then it will go up the left atrium, stretch it, back through the pulmonary veins and up into the lungs and fill up with fluid. The child's going to look like a congestive heart failure. They're going to tire easily. They're not going to eat. They're going to be a failure to thrive because they're not getting nutrition. Does that make sense to you? Okay. So, cardiovascular dysfunction. Some of them we see at birth, some we don't. I actually had a coarctation at 3 months old came in, and we diagnosed it at our hospital. Nobody else did before us. They couldn't figure it out. So what do you say? Poor feeding. They're tired easily and they're not getting oxygen, right? Not getting enough around to where it needs to go. They're breathing faster because they're full of fluid. They're tachycardic because all this fluid, they're trying to get oxygen around and they can't. Of course, they can't eat because they tired easy. So failure to thrive. Activity intolerance, they can barely eat, so they're not doing much else. Poor nutrition, you're going to see developmental delays. You might see it because they knew about it prenatally, or there might be a positive history which makes you look for it, but many times you're not going to see that. You have to figure it out yourself. So we look at nutritional status, the color of the infant. I mean, at birth, the kid is pink. They always come out pink. But you start seeing this bluish color, you need to start looking. Look at the chest. Do you see it retracting? Do you see buzzing going on that chest? Because that unusual pulsation or like buzzing, hissing, with just touching with a hand is probably a big murmur. It's what it sounds like, and you could feel it. You're going to see them breathing harder. And older children, you're going to see their fingers clubbed, just like the old COPDers. So you're going to look at the chest, look at the belly, check those peripheral pulses. You know, that did clue me in. Take those blood pressures. Look at the heart rate. I mean, 184 in a newborn at rest is too high. It's 140 to 160. Respiratory rate is, you know, now 80. It should be 40 to 60. Something's going on. And that, as a nurse, you know, I'm inquisitive. I want to figure it out. You know, I want to tell the doctor what's happening. That's always just been me. So what are we going to do to this child? Well, of course, they're like connected to the EKG, their SAT probe, and we can do little echocardiograms if we're thinking it's cardiac. I'll tell you, if you're doing an echocardiogram on an infant and they find anything, that child is going to go for a cardiac catheterization soon. So cardiac catheterizations can be done for 2 reasons. Well, one, just to figure out what's happening before they need to go to surgery, to figure out where all the anatomy is. And it does help the surgeon quite a bit. Now, interventional is different. It's almost like the electrophysiology studies. And I'll explain it to you as this. Some children have these times where the heart just beats really quick and then it goes normal. And then it beats really quick. They call them tachydysrhythmias. And what it is the SA node is bullied by another little area in that right atrium and says, I'm going to beat for you. You shut up. I want to beat. And that right atrium starts beating. And then the SA node says, that's enough of you. I'm going to continue to beat. But you don't want those tachydysrhythmias because it hurts the heart, right? It's overworking it. So you go to these electrophysiology studies, they find out what the bully is that's trying to beat too much, and they zap it with a laser and they stop it. So electrophysiology studies are to zap different things, and there's all different sort of things interventional they can do. I'm not going to go into all of them because I don't want to drive you crazy with all the information you don't need yet. So cardiac cath, you've had this kid's gone to, you've prepared them, they've gone to a cardiac cath. You know, it's just like you're sending them to surgery. They're going to be NPO for a certain amount of time. They need an IV and they go to the cardiac cath room. They do their study, they find out what's going on. When they come back to the room, they have cannulated that right femoral vein and right femoral artery with huge, huge catheters. They pull them out and hold it till they stop bleeding. They put on a pressure dressing. It on that movement of putting them from table to their bed or whatever, they could have jostled, that femoral artery area, and it could pop the clot off and it could bleed. So it's either a big hematoma is forming or it's bleeding, squirting blood. So first priority, check the insertion site of those catheters because it's gonna bleed. And an infant could bleed out in 5 minutes, quick. I mean, it's a huge, huge vessel. You'll do vital signs to check what they are. Of course, the dressings first you do. And, either IV or PO fluids, depending on patient condition. And children tend to show stress through glucose. So we're going to monitoring blood glucose. Furthermore, they might have gotten a little bit of glucose in their IV fluids in the cardiac cath. So you need to look at that and monitor it. Children do not like low glucoses at all. So then you're thinking congenital heart disease. How many are there? There's more than you could ever imagine. I mean, I was shocked at the amount of cardiac congenital heart defects that were there. Major cause of death in the first year of life, except for prematurity. The first common type of defect is that ventricular septal defect. What is that? Well, the ventricle, the septal, that little partition has a hole in it. So the right and the left ventricle can be entered into each other. It's a hole. It is one of the most common things you see with Down's children. Down's children can have ventricular septal defects. They can have AV canals. They can have truncus, but we're not going to go into the other two. Truncus, AV canal, everything's open type thing. So you don't have to know those for this course. So there are two types of congenital heart defects. Ones that you don't get enough oxygen, and the other ones that you get oxygen, like a ventricular septal defect, atrial septal defect, you have oxygen. There's no blocking of blood going to the lungs, okay? Now, the heart does certain things. It depends on blood flow. So we know that left ventricle is strong and it pumps. So there's a lot of pressure in there pushing blood around. So if there was a hole in between those two areas, we know that it's going to push blood to the lower area because the right side, it just gets the end of that blood flow because remember, it's the end of the line for where that heart has pumped. So the pressure there is very low. So usually it will go from the left side into the right side. Now, this again is in your book. It talks about acyanotic and cyanotic heart diseases. Now, there's different things you need to look at and, you classify them. So there are times when your heart is overflowing or recirculating blood. As I said, ventricular septal defect. It's going to go from the left side back up and the left to the right ventricle back into the lungs. So it's reflow. So any hole in the heart will cause that. Now, the other one is called a patent ductus arteriosus. Now, a PDA, patent ductus arteriosus, is there for fetal circulation. What does it do? It connects the pulmonary artery to the aorta. So we know that oxygen is getting to the body in fetal circulation because it's connected from the lungs to the body, to the aorta. So pulmonary artery to the aorta. Now, mommy, during pregnancy, secretes something called prostaglandins. It's like a hormone that keeps this vessel open. At birth, mommy's gone, we're not secreting prostaglandins, it will close, usually within 21 days. There are some conditions where you need oxygenation because there's no pathway to the lungs, and we need to keep that duct open. Some of the ones that you will see that need it: tricuspid atresia, transposition of the great arteries. Both need oxygen because the way that the body is formed, there's no connection to the lungs. So we need to make that and keep it open by keeping that patent ductus arteriosus open. So what we do is we put them on a slow, continuous infusion of prostaglandins, just like what mommy had, right? And it will keep it open and allow oxygenation. Now, what if you don't need it and it keeps open? We see this a lot in your premature infants. We see that, and we know because there's like a machine-like murmur going on in there because that duct is open. And we also see the blood pressure. I mean, a normal blood pressure is 60/40 on a newborn. You'll see wide pulse pressure. What does that mean? It means 60/20, 60/16. You'll see it's wide, and that says the PDA is open. And we need to close it. Well, you don't need to do surgery. We can do it through medications, and we do it through indomethacin. It is actually, there's pills that are an NSAID, but this drug has been found to stop the release of prostaglandins within the baby and will close that patent ductus arteriosus. Now, if after 3 tries of giving this drug indomethacin or Indocin, it doesn't close, then it will have to be a surgical intervention. Okay, next thing, obstruction to blood flow. I talked about coarctation. Now, there's 2 different things. There's a stenosis here, and then decreased pulmonary blood flow. You see atresia. When you see atresia, A without, nothing. There's nothing connecting it. Tricuspid atresia is where? Where's the tricuspid valve? It's between the right atrium and the right ventricle. No flow is going to the lungs. Atresia, none. Now, aortic stenosis, pulmonic stenosis, it's narrowed. It's almost like coarctation, a narrowing or a kink that's not allowing all the blood flow go. Many times we could just go in a cardiac cath, interventional balloon, with a balloon, open those areas and they do fine. But sometimes they do need surgery. Tetralogy of Fallot is your most common of all cyanotic heart defects. If you want to learn one diagnosis and know it well, tetralogy of Fallot. You will see that on the HESI. They love it on your NCLEX. This is a diagnosis I've always seen. Many students who get back to me after they passed their NCLEX said, you were right, tetralogy of Fallot was there. And tetralogy of Fallot is that blue spells, those tet spells. So mixed flow, transposition of great arteries. Well, what are the great arteries in the heart? This pulmonic artery and the aorta, they're switched. So that means you have, instead of the blood going from the lungs to the body, you have the lungs just recirculating. And then the aorta is going to the lungs and going. So there's no connection between these 2 things. This is a very serious congenital heart defect. It needs that patent ductus arteriosus to oxygenate. There's no other way for that connection of oxygen to give it to the baby. Now, once we start that prostaglandin infusion, that slow IV infusion, these children, you can wait 7-10 days to do surgery because they're getting oxygen. Many times we give them to the parents, they can feed them a bottle. Their saturations are 100, they do great. Sometimes Patent ductus arteriosus isn't enough, so sometimes we need to make a bigger hole between the right atrium, left atrium. I mean, at birth, they have that patent foramen ovale, right? It's that connection. You can, open it up bigger so there's more blood flow. And then the surgery that you take is called a arterial switch operation. Now, the other one is hypoplastic left heart syndrome. It is the worst of all of the cyanotic heart diseases. They're usually 3-stage surgeries. These children, are constantly getting catheters and, cardiac catheterizations, and, their saturations will never be normal. They'll always be slightly cyanotic. Many of these children end up with a transplant. So I left these slides in for you if you want to look at it. Increased blood flow. Which way does the blood flow? From the left to the right, because the left is higher pressure than the right. Goes into kinks and obstructions and mixed defects. So now let's go into what happened with that coarctation. And now the blood's flown back, that left ventricle stretched, and now it's all the way up into the lungs, filling up with fluid. And now we have a child who's just barely trying to breathe and can't eat and has no activity tolerance at all because they're full of fluid in there. So what do we do with congestive heart failure? Well, take an x-ray, we find fluid everywhere. We can see it. Plus, infants, how do they tell you that they're in respiratory distress? Well, they're going to have nasal flaring. Their nose goes in and out, just in and out. When they breathe in, it goes out. Then at the end of a breath, they'll have what we call a grunt. It'll go, every breath, you'll hear that. When you hear an infant nasal flaring with that grunt, that kid's about to crash on you. That kid needs to go into the trauma room and get ready because they are extremely sick, okay? Grunting, flaring infants is a serious thing. So our goal, what do we want to do? Well, we got to get that heart working better. Many times, believe it or not, we put them on digoxin, just like adults. Same treatment as adults. Same values of dig toxicity, 0.5 to 2, above 2, you're dig toxic, right? Heart rate on an infant, a newborn, it'll be down below 90, you're dig toxic. What else would you see in an infant? Well, they don't see yellow spots yet. They can't tell you that. They can't tell you they're nauseous, but they'll be vomiting or they'll be gagging. And you can see these infants gagging and vomiting. If they're on digoxin, you're going to hold the digoxin, call the doctor, and do a dig level. So in congestive failure, we'll be doing daily weights, monitoring I and O, giving some diuretics, furosemide, again, in doses, milligrams per kilogram. And what that does, getting rid of that fluid, gets the child breathing easier, decreases the cardiac demands, and we get more oxygen because there's more space in the lungs to give oxygen. So during all of this, you have an infant. We need to feed them. Now, if they're in congestive failure and can't breathe, guess what? You're not going to give it by mouth. Most likely you'll put a little tube in their nose to have them breathe. They'll be breathing and they'll still be fed as much as they can. And during this time, this kid looks sick. The chest is retraction. Their nose is flaring. You can tell that they're tired. These parents are like, oh my God, what's going on? Always make sure that the mother, the father is involved in the care in these children because it's scary. It is. And let them know what's up. So hypoxemia, well, we have congenital heart defects that cause cyanosis, right? Well, just like that hypoplastic left heart, I said you'll never have a normal saturation. So the body is pretty cool. It says, all right, you have not enough oxygen. Let me make some more red blood cells, because red blood cells do what? They carry oxygen around, right? So they produce more and more red blood cells to carry more oxygen around because their oxygen saturations are low. Well, there's no more oxygen to carry around, but that body doesn't know it. So it does something to produce these cells. Now, you might have a normal hemoglobin hematocrit of 12 and 36. When you're talking about cyanotic heart defects, it could be 18 and 54. I mean, really diluted with, it's concentrated red blood cells in there. And that is called polycythemia, when your blood is overproducing red blood cells. And this is a good picture of an older child that has the clubbing of the fingers. That could be your hypoplastic left heart, that's older, and you'll see that. So again, help those family adjust to it, educate them as much as you can, have them involved as much. It might be just helping you change a diaper or wiping their lips or combing their hair, but do those things to help and have them prepared for what the surgery looks like. It is scary. They've got chest tubes hanging out. They've had their chest open. They've got tubes from everywhere. Let them maybe, when they're prepared enough, see another infant, what they look like, so they can be prepared for the shock of what they're going to see. And you're always, always, always preparing a child for discharge on admission. When you're talking about bacterial endocarditis, you're going to say, well, what's the difference between adults and children? None. We know it's the inner lining of the endocardium, gets infections. And with this, of course, we treat it. But again, prophylaxis before anything, whether it's cardiac caths, dental procedures, we'll prophylaxis them. Now, strep throats. You say, it's a strep throat. Okay, yeah, you get them all the time. Well, there are two conditions in pediatrics that you're going to learn about that can be caused from a strep throat. And one of them is rheumatic fever. It affects the heart and it causes permanent heart valve damage, which means you might need replacement of those valves. It affects joints, the brain, you get rashes, and then also chorea, which is a type of wobbling walking that you can get. And how do we treat rheumatic fever when we suspect it? Well, we're going to treat the strep because that caused it. So it's going to be a long-term antibiotic to treat it. And everything will go away except the heart valve damage if it's already damaged that heart. They do have issues with high cholesterol, so we've learned to check children for it now. We didn't many years ago. Cardiac dysrhythmias, I've already talked to you about that tachydysrhythmia we went to the cardiac cath with. But what would you do if a child had a really low heart rate? They do get pacemakers. I mean, I had a little kid who was a little bit over 1 year old. The pacemaker was about the size of a $50. And they do that, but they put them in the abdomen. They don't put them in the chest. And it does work. But these things, remember, we have to replace those leads, those wires in the body, because they grow and they can disconnect. Pulmonary artery hypertension is when the lungs, they've been damaged and they get tight and they don't want to exchange oxygen and carbon dioxide. And if you're not exchanging your airs, you're going to have shortness of breath, chest pain, syncope because of lack of oxygen. The one drug that I saw them treat pulmonary artery hypertension with, when I first saw it, I was like, what? And it's Viagra. But it was a little girl, so I don't know if it affected the child in other ways, but Viagra causes dilatation and it does help with pulmonary issues. Cardiomyopathy, I mentioned that viral conditions can cause the heart to get weak and big and floppy. I mean, it could be due to infections or some nutritional thing, metabolic, collagen disorder. All these things can happen. And cardiomyopathy, we can give many meds to help these children have the best cardiac function they can, but most end up with a heart transplantation. And when you're talking about a heart transplantation, the number one thing that can happen is rejection. So that's why they're on these immunosuppressants afterwards to suppress those immune system so it doesn't fight the heart that's in there. So rejection is the big thing. Now, we used to not even test young kids for blood pressure, but we found out there are young children who have hypertension. Now, what happens when an adult has hypertension and doesn't treat it? Number one thing you think of, kidney damage, right? Because kidneys is the first thing when you talk about hypertension untreated, it's going to kill your kidneys. So we need to be concerned about high blood pressure in children. So now routinely, children walking into the ER ages 2 and 3, we are doing blood pressures just to make sure their blood pressures are okay. Another condition called Kawasaki disease. It's a systemic vascularitis, an inflammation of the vessels in the body, but we're mostly concerned about the coronary arteries. And this vascularitis inflammation creates these little micro emboli. So if it's in the coronary arteries, these microemboli can block off the coronary artery and cause a myocardial infarction. Or it can cause an aneurysm and it could burst and it cause the kid to die. So what is Kawasaki? Well, it's a virus. It's a virus that attacks the body. And these children, is again, so difficult to try to diagnose. Usually it's about 10 days down line when they finally are showing more symptoms that we figure it out. Now they've got these little fine rashes here going on, but the big red glow in the dark eyeballs is big with it. They have strawberry tongue, you know, the palms of their hands, the soles of their feet, they're peeling, they're swollen, even blistered that's going on, you know, and the little red cracked lips we see. So how do we treat it? Well, it's a virus. So we treat them with intravenous gamma globin, it's IVIG, and it's an IV, and it's usually for a month they do this, sometimes longer. And we give high dose aspirin, the only time we give aspirin to children. So why aspirin, you might say, right? Why aspirin to a kid? You're not supposed to do that, Raynaud syndrome. Well, aspirin thins the blood, and it also helps with the inflammation of the itis in that vascularitis. So aspirin helps with the clots and it helps with the blood flowing. It's like giving them a Coumadin. It thins the blood type thing, but also with the inflammation, because it's an NSAID, so it helps with inflammation. Shock. Shock can happen in any child for any reason. Most of the time in shock with children, it is due to sepsis, septic shock. What do you see with shock? Well, the heart gives up, low blood pressure. Then the heart says, well, let me try to be a little quicker to try to catch up. So tachycardia, hypotension, and then you'll see poor perfusion, decreased urinary output, you know, all of these things you'll see all together. And how do we treat it? Well, we treat why they're in shock. It's sepsis, we're going to give them their antibiotics. Or if it's anaphylaxis, give them the epinephrine and steroids, you know, and we'll just support these children with all the drugs we give adults, dopamine, epinephrine, norepi, isoprel, all these things we can give them to infants, but mics per kilo, milligrams per kilogram doses. So a question, let's see if you listen about PDAs. Remember, a PDA connects the pulmonary artery to the aorta. So surgical closure of that patent ductus arteriosus does what? That left ventricle is pumping high pressure, pushing off and going to the aorta. If that duct is open, it's going back to the lungs, that oxygenated blood. So if we cut that off, it's not there anymore. It's going to prevent the return of oxygenated blood to the lungs. So the answer is D. Okay. All right. A lot of concepts today, a lot of things to think about. Pretty intense, as I might say. So who wants to win cahoots today? Brian does. Always he wants to win. Yaris, yeah. You? Okay. Tech, you'll be up there too. Jabari, I know you will too. Brianna's usually there too. Let's go and do it. Three 076. Big B. And let's get going. Should be out maybe 5-10 minutes early tonight, hopefully. There's 52 questions. A majority of upper respiratory infections are caused by what? Go into the doctor's office, got a fever, you're coughing, got a lot of nasal mucus. What does he tell you? It's a virus. Most of them are viruses. They will not treat you for an infection until a kid is sick over 3 days. Then they'll put you on the antibiotic, not before. It's always considered a virus until they find something else out. A multi-select. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Now, this one I didn't go over. This is your question about it. It is a respiratory issue. And the thing about it, this cough is so bad that they usually order you a narcotic cough medicine because you cough so hard, you hurt. Your chest hurts, you cough so much. And it is, again, they'll put you on a Z-Pack and they'll give you cough medicine. And it's either called, and it's the same thing, bronchitis or tracheobronchitis. It's the same word. It's the same thing. Asthma, it's not dry, bothersome. There's wheezing. There's, expiratory, prolonged expiratory thing. Pneumonia has nothing to do. It's a wet cough with pneumonia. So bronchitis. The monthly immunization for RSV is. So HIV is your hepatitis given at birth. Humira is what you use for things like rheumatoid arthritis. Indocin or indomethacin is what closes the PDA when you want it closed. Synagis or palivizumab is what we give monthly from early winter to early spring. Every month we give it to those children who cannot tolerate extra mucus. All the following are signs of early respiratory distress in children, except. So you have to know, what are signs of respiratory distress in children? So usually in respiratory distress, you're tachycardic, you're nasal flaring, an infant might be grunting, you're diaphoretic, you're restless because you're getting no oxygen. By the time you're bradycardic, this kid's about to crash and burn. This kid's probably going to end up intubated and almost coding. So a kid who's not, heart rate is slowing down, you're in trouble. Tell somebody, scream for help. A 4-year-old child's been taking meds for asthma and the child's still wheezing. What information is important? What are you going to ask that child, that parent? Absolutely. Are you using a spacer? How are you giving the medicine? Because sometimes they come in, they're wheezing. I give a spacer, we give it, and their wheezing decreases. And I prove to the parent how important that spacer is. And I send them home with a spacer. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Remember, children of all ages, all different numbers, all different norms. So respiratory rate of 25, a pulse rate of 88, that's actually a kid sound asleep. That kid's fine. Abdominal breathing, pulse of 100, heart rate isn't big enough. I'd say 120, 130 would be heart rate because they're real respiratory distress. It doesn't matter their O2 sats of 95, that's okay. But they're starting retracting, now they're restless. That means they're not getting oxygen. That restlessness, key thing, adults, children, don't matter. Restlessness, think oxygen, lack of. Signs and symptoms of asthma include all except prolonged expiratory phase. Remember, they get air in and it's swollen and it gets stuck and it comes out and goes hardly. It's all you hear. Hacking cough, oh yes. Cough, 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 cough. Shortness of breath, wheezing, absolutely. Shortened, no. Prolonged. Signs and symptoms of congenital heart disease include all except so this kid is working so hard, the heart's working so hard, it's burning calories, you're not eating good, they're not going to have an appropriate waking. Excellent, good job. What should you not do to children diagnosed with croup and epiglottitis? Never look into a mouth who's having difficult child who's working too hard to breathe with that barking and suspected epiglottitis. You're just going to make that swelling get worse. The epiglottis is what? So it's that leaf-like structure that covers the trachea when you swallow to prevent choking. Yes, all of them. A multi-select. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? So I want to know their fevers, where they've been, immunizations, of course, and then what time the medications were given, because I'm going to have to give Tylenol or Motrin somewhere around there. So, but immunization is so important. I want to know what respiratory stuff I'm working with. What is cystic fibrosis? I have a couple of questions in the Kahoots regarding this, and I'm going to go over it. And what it is a two-component thing where the lungs get filled with mucus and the small intestines gets filled with mucus, and the body has an inability to absorb nutrients. So these children must take an enzyme, pancreatase enzyme, before they eat. They lose fat soluble vitamins and fat in their stools, so their stools can be really loose and nasty smelling. So how do we treat them? Excellent chest physical therapy, all sorts of aerosols, etc., to keep that loose, because it's like a petri dish. If you don't, it's thick, it grows stuff. And then, of course, to give them the nutrition, we're going to be giving them the pancreatase so that they can absorb the nutrients they need to live. What is the greatest risk for an infant having a cardiac catheterization? So an infant has two big holes that was put in the right femoral artery and vein, and they've held the pressure, but we didn't check it when they got back. Let me tell you, they could have bled all their blood out, or they could have a huge hematoma there. So the biggest risk is the hemorrhage. They can literally bleed out in 5 minutes. It's that quick, they can lose their blood. How is cystic fibrosis identified? Now, usually cystic fibrosis, we find either we know because the parents have other children or they do have cystic fibrosis, but a child who does not move their bowels within the first 2 days of life, they're going to test them for cystic fibrosis. And what they do is a sweat test because there's salt on the skin from their sweat. I mean, if you were to lick this child, and I'm not telling you to lick a baby, but if you licked them, you would taste salt, like really strong salt on their skin. So these children, you need to give them salt in their diet because they're losing it. Another multi-select. What is included in the plan of care with a child with cystic fibrosis? Remember, it has to do with the lungs and nutrition. So absolutely an aggressive physical therapy. They're losing fat, so they need protein. They need a high protein diet. The pancreatic enzymes immediately before they eat. And you will give these children a regular sodium diet. They're losing salt in their sweat. They need it. So not a low, regular sodium. What is the drug of choice for a pharmacological closure of a PDA? So we keep it open because of prostaglandins. Mommy has it during pregnancy. Mommy delivers the baby. Mommy's not there anymore. If we want to keep it open, we give prostaglandins. If we want to close it, it's indomethacin. Indomethacin is an NSAID, but it works, and we give 3 doses. If that doesn't work, we'll do a surgical closure. Synagist is for what? RSV. Vitamin K is given at birth because their blood is so thin. What is not a feature of tetralogy of Fallot? Remember, tetralogy of Fallot is all right-sided. So when you talk about what's not right side, where's the aortic valve? It's the valve that goes from the left ventricle to the aorta, to the body. That's left-sided. So aortic stenosis is not tetralogy. When you talk about tetralogy of Fallot, that pulmonary artery gets covered and kinks, and blood can't go up in there, and it causes a TET spell. And when we want to have a kid, I've had infants go into tet spell on me. So you take them, you put them knee to chest, quick, like a quick knee to chest. And what that does, it changes the pressure in the abdomen to the chest cavities, and it opens up that blockage and allows blood to flow. These are those blue spells that you see. I mean, there are children that are older that are not fixed, and they just know just to squat on the floor, which is like a knee chest, isn't it? And what they do is that knee to chest right to the floor takes the abdomen up against the chest cavity, and again changes pressure and allows blood to flow. What medication would you hold for an infant that is vomiting? Vital signs are 98, 88, 32. Well, vomiting in a heart rate of 88, below 90, you're going to consider ditch toxicity. You're not going to see like the yellow spots and nausea things, but you will see a kid vomiting, and you know the heart rate of 88 is way too low on an infant. Just for a side note, all of these medicines that are listed all can be given to an infant. There's not infant cardiac drugs. They're adult drugs in pediatric doses. Why would a child with tetralogy of Fallot not gain weight at a normal rate? So tetralogy of Fallot, they have issues where they're hypoxic, so that inadequate oxygenation, no energy, they can't eat. So they're gonna be small. They're not gonna gain weight normally. All are examples of cyanotic heart murmurs, except which one? And it's not truncus. What is not cyanotic? Truncus is just an opening of all the valves. It's like a wide open heart. So remember, stenosis is still an opening, right? And aortic, it's still gone to the heart. When it starts to go out to the body, it's a little smaller, but it's still all oxygenated blood. We know tetralogy is the most common of all cyanotic heart diseases. And tricuspid atresia, how is the blood going to the lungs? Without no opening between the right atrium and the right ventricle. So absolutely, it's cyanotic. What is the most common cyanotic congenital heart defect? Tetralogy of Fallot. Tetralogy of Fallot. PDA, what does it do? It makes you oxygenate. It's a connection between the lungs and the body, the pulmonary artery and the aorta. It's connected. That means there's oxygenation. We use this PDA to keep children alive who cannot oxygenate by themselves, like that transposition of the great arteries or tricuspid atresia. We make sure that oxygen goes to the body. Nursing care following cardiac catheterization. So we absolutely are going to check that insertion site for hematoma. We can slowly lift the head of the bed, but not too quick because we don't want that clot to come off. That leg must maintain straight, and they are on bed rest 24 hours. Okay, but your most important thing is checking that site for a hematoma or bleeding. Multi-select. Nursing education for cardiac catheterization include all except. So you're not going to ambulate and you're not going to bend that extremity. Those two things will have that clot come off, and we don't want to do that at all. Which information is most important to ask when rheumatic fever is suspected? How do you get rheumatic fever? Strep throat. So a recent episode of pharyngitis, they may not have gone to the doctor. They may have, just kept it home and whatever, or they didn't finish the antibiotics. Those things can cause a child or adult to go into rheumatic fever, and you could have permanent heart valve damage. Signs of shock in children include all of the following except. So shock, hypotension, tachycardia, altered mental status because you're not getting oxygen to the brain, poor capillary refill because all the blood goes back to the core. Hypertension? No, absolutely not. Hypotension. What is the treatment for Kawasaki disease? Remember, it's called systemic vascularitis. And our biggest concern is the coronary arteries. So we give aspirin to prevent clots and to keep the blood flowing. And we give IVIG because they need those immunoglobulins to help the body fight because it's a viral disease. So antibiotics will do nothing. Which of the following best describes the pathophysiology of Kawasaki disease? So whenever you think Kawasaki disease, think of coronary arteries and the vessels. That is our biggest concern because the clots can clot off a coronary artery, cause a heart attack, or it could have an aneurysm and explode and cause the death of a child. Multi-select. A clinical manifestation of Kawasaki disease is what? So it can do the erythema marginellum, but the name of the rash isn't necessarily that, but it is a rash. So yes, it is. But the blistered cracked palms on the palms and the soles of the feet, big red eyes, strawberry tongue, chorea are all classic signs of Kawasaki. Which of the following is the most common cause of shock in infants and children? So we know it's sepsis, which is caused by an infection. It's the biggest common cause for children, infants and children, absolutely. What are the defects associated with tetralogy of Fallot? Again, remember, it's all right-sided. So it is that pulmonary artery stenosis, that VSD. The aorta sort of gets pushed over. And because blood can't go into the lungs, that ventricle stretches out a little bit, which is called right ventricular hypertrophy. Good job. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell? And they squat. They just squat right to the floor, just like the picture there. They just go down. And again, it's like knee chest that we do for infants. It's the same thing, and it works for them. I mean, not many children go that far without repair, but there are some children with tetralogy who are not repaired yet. Transposition of the great arteries is what? What are the great arteries? And transposition means they're switched. So the pulmonary artery is where the aorta should be, and the aorta is where the pulmonary artery should be. So there's no mixing of blood. To keep this child alive, we put him on prostaglandins, which keeps that patent ductus arteriosus open. Which of the following is not an intervention indicated for transposition of great arteries? So we're going to put them on transposition, gets prostaglandins. We need to oxygenate that child. We have pulmonic and systemic circulation not mixing at all. This child's getting no oxygen. So that prostaglandins is what is needed to keep open that PDA. So absolutely number one. Number two, sometimes they need a little bit more mixing. So they take and open up that patent foraminal valley in that right atrium area, and they punch it with a hole, make it bigger. So we're getting flow of blood there too. And then the surgery we do is called an arterial switch. Now, oral vasodilators are not going to do anything. This is an extremely serious condition, congenital heart defect. So oral won't do anything for that child. A multi-select. Why is prostaglandins given to a child with transposition of the great arteries? What does it do? So it helps keep oxygenation, and it also helps with cardiac output. Both of those things has nothing to do with an infection. Prostaglandins is not an antibiotic. It doesn't treat any infection. It just keeps that PDA open so we can get blood from the lungs to the body. That's all it does. What's the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? So we know that the patent ductus arteriosus is kept open by prostaglandins, whether through mommy or through a continuous slow IV infusion. Now, when we want to close that duct, that means that baby somehow still has a little bit of prostaglandins in there. So what it does is says that prostaglandins go away, and then it goes away and the duct naturally closes. Usually within 3 doses it happens. If not, they need surgery and they'll do a closure. Where is that patent ductus arteriosus? I've told you a few times now. So it connects the aorta to the pulmonary artery. So the pulmonary artery is oxygenated, can give oxygen to the body through the aorta. Simple. This heart defect allows blood to pass from the left ventricle to the right ventricle. What is that called? So if you have a hole between ventricles, it's called a septal defect. If it's in the ventricle area, it's called a ventricular septal defect or a VSD. Now, what if that hole was between the right atrium and the left atrium? It's an atrial septal defect, okay? I'll multi-select. What is a sign of digitoxicity in an infant? So you're going to see that vomiting and the heart rate. Now, how many infants have told you I'm seeing yellow spots? Ain't going to happen, okay? An infection has nothing to do with digitoxicity. So that vomiting or that retching, you might say, like, ooh, ooh, you would see. And that low heart rate, that's telling you. What do? Hold the digoxin, call the doctor, do a dig level. What is congestive heart failure? A coarctation causes congestive heart failure. Kinks off the aorta and blood goes backwards. Absolutely, it's the heart's weak and it can't get rid of the fluid, and yes, it builds up. Very good. Left-sided congestive heart failure causes what? It's a trick question. So if we see left-sided, it means things are going backwards. So it goes into the lungs, all this fluid. So what do you see? Shortness of breath, fluid in the lungs. And of course, you're coughing because of all the extra fluids. Good. I'll multi-select. Signs and symptoms of rheumatic fever include what? All the above. It's a rash, chorea, which is that weird gait wobbling, polyarthritis and subcutaneous nodules, and everything will go away with treatment. It's due to a strep pharyngitis. Treat the strep with an antibiotic. Everything will go away except heart valve damage. After a heart transplant, what is the leading reason children die? It's rejection. Rejection's the number one reason why a child will die after a heart transplant. That's why they're on those immunosuppressants for life, to try to stop rejection. I'll multi-select. A child's about to have a chest tube removed. What should you do? I mean, post cardiac surgery, they could have 4 chest tubes in. And once they stop draining, they're going to be taken out. And the one thing I can tell you with this, it hurts. You need to be honest to that child. It's going to hurt for a little bit. It's like it comes out, it burns, and then it goes away. So explain it to them on their level, medicate them before, also vital signs before and after, because you're going to give pain medicines. And of course, tell them it's going to hurt just a little bit. You are going to have them more in a Fowler's position. You're removing chest tubes. You want that diaphragm down. You want them to breathe. So you would have them elevated also, the head of the bed. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What is your priority? His kid needs to get this lung moving. He's going to have atelectasis. What are you going to do? Because he can't cough good enough. What's going on here? So number one priority, you have a kid who's just had surgery and it's not coughing, he's probably in pain. Medicate for pain, then you can move their position, get them out of bed, use incentive spirometry. Have you ever had abdominal surgery and try to do incentive spirometry or get out of bed? You're not going to do it. Okay, so a child, please medicate them for pain, and then we could do the rest to help with pulmonary toileting and preventing all the complications. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? You can only give acetaminophen, Tylenol, up to the age of 6 months. That's it, nothing else. At 6 months, you can add ibuprofen. Apparently, ibuprofen has something with bleeding coagulopathy and platelets that a younger child cannot tolerate. You can only start ibuprofen at 6 months. And that's when you'd alternate Tylenol and Motrin for fevers. So up to that point, you only have acetaminophen. A newborn is assessed. The nurse finds very weak lower extremity pulses. What should she assess next? Very weak lower extremity pulses. In fact, they're really not there. I think they might, but I don't really feel them. What should you do? What are you going to assess next? So I'm telling you, it's probably coarctation of the aorta, right? You don't have any pulses in the lower extremity. It's a newborn. So it's probably coarctation. So the next thing you do is do that for extremity blood pressures. What are you going to see? Well, no blood's getting down there to the bottom. So lower blood pressures on the lower extremity. And because more blood's going up, we're going to have higher blood pressures on the upper extremities. And that's almost guaranteed you what your diagnosis is. I'll multi-select. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? I mean, does it matter if it's a child or an adult? They're on complete bed rest. What are you going to do? So we're going to use the incentive spirometry. You know, children, I put little baby blankets behind them, underneath their knees, around them to keep them up and over, keeping them dry and clean, whether chucks, whether a diaper, whatever. And if we can, with a condition warranted, elevate the head of the bed so that their diaphragm's low, they can breathe better. Good job. I'll multi-select. How can oxygen be delivered that's easiest tolerated and accurately monitored for infants? So the oxy hood is this clear plastic shield, and we can deliver whatever amount of oxygen you want to deliver. We can monitor it easily. And that kid can suck his fingers, suck a pacifier. It's great. Now, nasal cannula is the second thing. But there's these little things that tickle the nose and blow air, and it's usually taped to the skin, and they take their little fingers and they get like that and they pull it off, and they can rip their skin. The best one of all, oxyhood, but nasal cannula would be second. Now, blow by, it's not accurate. And easiest tolerated in the tracheal tube, have you been intubated? It is horrible. I have been. You feel like you're gagging and choking, and you know that you should be able to breathe. So best thing is oxyhood. Second, nasal cannula. Another multi-select. What procedures are used to keep the lungs open with a child with cystic fibrosis? So we're going to do all the respiratory things we possibly can. Deep breathe, chest PT, exercise, and not ambulating PRN probably 2-3 times a day. It's not as needed. It's yes, you need to ambulate to get those lungs moving. Another multi-select. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? It's a question also on your case study. So you definitely need to give it right before the meals, not an hour, not 2 hours before, right before meals. You can sprinkle it on their food, but if they're doing this powder thing, make sure they rinse their mouth out because it can hurt the teeth. And the one thing we forget, when children get older, they need a bigger dose. So make sure their dose changes as they get older. What is a cardiac defect when there's no valve between the right atrium and right ventricle? What valve is between the right atrium and right ventricle? And there's no opening A without definitely tricuspid atresia. Stenosis, those things have nothing to do with it. And, you know, this is a defect, again, highly cyanotic. It needs your PDA open to be able to live. Last question. When an infant is breathing fast, tires easily, and needs rest periods during feedings, what should you assess? What do you think is going on here? So it's probably going into congestive heart failure. Breathing fast, needs periods for feeding. That means they're not getting oxygen. Yeah, check those breath sounds. Probably you're going to hear a little bit of something going on there. And here we go. Number 3, Tiff. Good job, Tiff. Number 2, Abby. Good job, Abby. And the whole game, Jessica. Good job, Jessica. Jabari, number 4, and Shauna. Good job, guys. What I want you to do is sign your attendance attestations. Make sure they're done. Anybody with any questions, comments, concerns, always make sure you email me. I'll take care of you. I'll answer your questions. If you want to see me for your exam, just let me know. I'll be available on Wednesday, Thursday, Friday. Tomorrow, I'm pretty full up already. But on Wednesday, Thursday, Friday, I will meet with you. I mean, it's not going to be an hour-long meeting. You want to know about your exams, as quick as you want to get through it, we will. So just let me know what you need, and I'll be there for you. Thanks, guys. Have a good evening.
Thanks. Bye.
Oh, thank you for tolerating my voice.